Hello everyone. Welcome back to the series of lectures in pulmonology. Today we will be discussing about interstitial lung diseases. So let's begin. So what exactly is this interstitial lung disease? Interstitial lung diseases are basically a group of lung parenchymal disorders which affects the interstitium. Right? So interstitium is the space which basically is present between the airways and the vasculature, and if there is fibrosis of that area, we call it interstitial lung diseases. So let us look at the classification of interstitial lung diseases. So interstitial lung diseases can be due to a known cause where you can have a trigger or an exposure which results in the ILD, or it can be due to an unknown cause. So this is the broad classification of ILDs. Okay. So ILD of a known cause can be due to exposure, or it can be secondary to systemic diseases. So what are the exposures which can predispose to ILDs? It can be occupational exposures like asbestosis and silicosis. We had learned this in our chapter on occupational lung diseases. Okay? Or it can be secondary to certain treatment management options that we use like radiation related. So there can be radiation exposures, for example, in your patients with breast carcinoma or thyroid cancers or certain lymphomas where you can use chest radiation. So that itself is a predisposing factor for ILDs. Then the drugs which can cause ILDs include long-term use of Methotrexate, Amiodarone and Nitrofurantoin. So these have been associated with ILD. Then certain chemotherapeutic agents like Bleomycin. Right? So Bleomycin can be associated with pulmonary fibrosis. Then connective tissue disorders. So when we look into your chapter or section on rheumatology, we know that there are a group of connective tissue disorders which can be associated with ILD. So what are they? They are rheumatoid arthritis, scleroderma or systemic sclerosis, polymyositis or dermatomyositis, and then we even have ankylosing spondylosis. Okay, so these are the group of connective tissue disorders which can be associated with interstitial lung diseases. Then vasculitis like GPA and EGPA, right? So what type of ILD do they cause? They cause something called as granulomatous vasculitis related ILD. Okay. Then certain granulomatous lung diseases. How is it different from the other connective tissue disorders? Because this is associated with a non-caseating granuloma in the histopathology of your lung sample. That's why they are called as granulomatous ILDs. And under that, you always remember sarcoidosis and hypersensitivity pneumonitis. Okay. So hypersensitivity pneumonitis is basically a hypersensitive reaction to inhalational exposures. For example, your bagasosis, for example, your thermophilic actinomyces related diseases. So that falls under your HSP. The other granulomatous ILD that we should be knowing is your sarcoidosis. Then ILD of unknown cause. So till now whatever we learnt was ILD of known causes, secondary to exposure, secondary to autoimmune disorders. Now ILD of unknown causes can be idiopathic interstitial pneumonias, which we call as IPF, and this is one of the most common causes for your ILD of unknown cause. Then we have your respiratory bronchiolitis associated ILD, desquamative interstitial pneumonias, cryptogenic organizing pneumonias, acute interstitial pneumonias, LIP pattern, which is your lymphocytic interstitial pneumonia. All of these are ILDs of unknown causes. So what are these different names? These are names which arrive basically because they are different with respect to the CT findings and with respect to the histopathological findings. Okay. Then there are also a group of ILDs which are grouped separately, which includes your lymphangioliomyomatosis, which is called as LAM. Okay. Then we have your PAP, which is your pulmonary alveolar proteinosis, Langerhans cell histiocytosis and pleuroparenchymal fibroelastosis. Okay, so these are the basic ILDs which are grouped separately, and these are ILDs of unknown cause where we really do not know what is the reason for the development of ILD in these patients. Okay, but the most common of these under this category is your idiopathic pulmonary fibrosis. Okay, so this is in broad about your classification of ILDs. So what have we learned till now? Interstitial lung diseases are a group of disorders which affect the parenchyma of the lung. So interstitium is basically the area between the airways and the vasculature. And how do they present? They are going to present with a chronic long-standing dyspnea. And the basic pathogenesis is that there is fibrosis of this interstitium which results in the ILD. Okay, fine. Now let us understand certain CT findings of various ILDs before we go and try and understand each of the ILDs separately. Okay, so first when we look at a CT scan, there are certain terminologies that we should be aware of to understand the different types of ILDs. So first we see whether the pleural surface is involved or not. Then we look at the nodules. So in an ILD in the CT, you can have nodules, you can have evidence of fibrosis. So the arrangement of these nodules can help us determine what pattern of interstitial lung disease it can be. Okay, so if there is no involvement of the pleural surface, then you look at the pattern of nodules. So you can see here in this first pattern that these nodules are basically arranged within the lobules of the lung, right? So this is one lobule, this is another lobule, and you can see certain nodules which are arranged within the lobules of the lung, or you can have a single nodule within the lobule of the lung, or when you look at it in the cross section of the CT, and this is what we call as the centrilobular pattern of arrangement of nodules. Okay, sometimes you can also see that there is a vasculature within and surrounding that the nodules are placed, and this is what we call as the famous tree in bud appearance. Tree in bud appearance. Okay, so this tree in bud appearance you would have seen in another very important disease. We had learnt it in bronchiectasis under non-tuberculous mycobacteria, Mycobacterium avium complex, correct? So non-tuberculous mycobacteria lung disease can also result in a tree in bud appearance, but the other condition where you can have this tree in bud appearance of nodules on the CT chest is your ILDs. Okay, so the first pattern, first you see whether the pleural surface is involved. If the pleural surface is not involved, you look for centrilobular arrangement of nodules. Okay, then if the pleural surface is involved, you see what is the type of arrangement of nodules there. Is it present diffusely throughout all the lobes, or is it following a particular pattern? Okay, so if you can see in this image, so this is the cross section of the lung. So this is the pleural surface. This is the pleural surface. Okay, then each of the lobes are divided by septa, right? And we know that when you look at the cross section of the lung, you will have vasculature which are coming this way, right? So you have vasculature which are coming this way, and there can be nodules which are distributed along this vasculature like this. Okay, so this is what we call as the perilymphatic or the peribronchovascular. Okay, so this is what we call as the perilymphatic or the peribronchovascular distribution of nodules, and this is seen in two important conditions. It is seen in sarcoidosis. This is seen in sarcoidosis, and it is seen in a very important condition which is called as lymphangitic carcinomatosis. Okay, where you can have spread of certain tumors in the lung along, and the nodules are distributed along the peribronchovascular space. Okay, so two conditions where you can see this peribronchovascular distribution of nodules is sarcoidosis and lymphangitic carcinomatosis. Okay, then there can be conditions where the nodules are distributed throughout the lungs, and this is what we call as the diffuse pattern as it is denoted here. Okay, so what are we looking at? So to understand the different patterns of ILD, before we go on and try and understand each of them, we should be knowing certain terms which basically refer to the appearances on the CT scan, and that is what we look at. We have understood how do we describe the nodules and changes on the CT scan to diagnose an ILD. So if there are nodules, first you see if the pleural surface is involved or not. If it is not involved, see for the distribution of nodules in a centrilobular pattern or a tree in bud appearance, or is it a peribronchovascular pattern, or is it a diffuse pattern. So if these terms are clear, then we can understand each of the type of interstitial lung diseases in detail. So let us see how will you differentiate each of these types of interstitial lung diseases. So the first and the most common is your idiopathic pulmonary fibrosis, okay? And the pattern is also called as the usual interstitial pneumonia pattern. Okay, so this is what we call as the usual interstitial pneumonia pattern or the UIP pattern. Okay, so the idiopathic pulmonary fibrosis, as the name suggests, is an idiopathic phenomenon. It is classified as an ILD of unknown cause, right? So what are the clinical features? Similar to any other ILD, it presents with chronic dyspnea. It presents with chronic long-standing dyspnea on exertion. So it can be confused with a heart failure. It can be confused with a pulmonary hypertension. Okay. So it presents with a chronic long-standing dyspnea. On examination, a very important finding will be you can find evidence of clubbing, and in more advanced cases you can find evidence of cyanosis. You can find evidence of cyanosis, and on auscultation there is a characteristic crepitations that you find that we call as velcro-like crepitations. Okay, so this is a most important clinical findings that you can find in your interstitial lung diseases. Okay, fine. So what is the cause for IPF? Is it associated with any exposures? No. We know that the exposure related ILDs are asbestosis, silicosis or hypersensitivity pneumonitis. So IPF is not associated with any exposure. Okay. So now let us look at the HRCT findings of idiopathic pulmonary fibrosis. So there are certain keywords which you should be remembering in the HRCT findings of IPF. So the first word, the characteristic feature of IPF is that it involves the lower lobes or the base of the lung. So base of the lung is the one which is commonly involved in your idiopathic pulmonary fibrosis. Okay, fine. So that is the first characteristic. Second characteristic feature is that it has subpleural reticular findings. Okay, so you can have subpleural reticular fibrosis which is found in your IPF. Okay, so subpleural reticular fibrosis, right? The third characteristic feature is the presence of what we call as traction bronchiectasis. Traction bronchiectasis. So we have learned in our bronchiectasis chapter what is bronchiectasis. It refers to dilatation of the bronchi. The most common etiology of bronchiectasis is because of mucus impaction due to secondary chronic infections leading to dilatation. So what is this traction bronchiectasis? This means that the parenchyma which is surrounding the bronchi is fibrosed, and this causes a traction or a pull on the bronchi leading to dilatation. So if you see, this is the bronchi, there is fibrosis here, and this is going to pull the bronchus leading to dilatation, and this is what we call as traction bronchiectasis. So traction bronchiectasis is a characteristic feature of idiopathic pulmonary fibrosis. Then you can have an appearance that we call as the honeycombing appearance. We will be looking at the images again, but this is what we call as the honeycombing appearance. Okay, so remember the keyword in IPF, you have predominant involvement of the base of the lung, subpleural reticular shadows, traction bronchiectasis and honeycombing. Okay, so in histopathology, what do you find? You find evidence of fibrosis. So if you do a reticulin stain, you will find evidence of fibrosis. Okay, so let us look at the course. Most of the patients of idiopathic pulmonary fibrosis have a poor prognosis. It has a 50% 5-year mortality rate. So that is about IPF. Now let us move on to the next pattern of ILD, which is your non-specific interstitial pneumonia. NSIP pattern, which is non-specific interstitial pneumonia. Similar to IPF, the clinical features, physical examination are going to be more or less the same. And remember, NSIP pattern is more commonly seen with a lot of connective tissue disorders. So the physical examination findings, you can find evidence of other CTDs. Okay, fine. So how is the HRCT and histopath of NSIP pattern different from UIP pattern? The characteristic feature here is that there is subpleural sparing. There is subpleural sparing. And it shows the presence of ground glass opacities. Okay, what is ground glass opacities? Basically glass like semi-white. You can find these kind of shadows in the HRCT of an NSIP ILD. We'll be looking at the images again. So you find ground glass opacities and subpleural sparing and honeycombing. Honeycombing is not found. Honeycombing is not found in your NSIP pattern. Okay. So remember, how is NSIP different from UIP? There are bilateral GGOs, there is no honeycombing pattern, and there is subpleural sparing, and you can find thickening of the bronchovascular bundles. Thickening of the bronchovascular bundles. Okay. So these are the most important differences between your HRCT findings of IPF, which is your UIP pattern, and your NSIP pattern. Okay, clear? Alright, fine. Now, the third pattern that you have to know is your RB-ILD, which is respiratory bronchiolitis associated ILD. Okay, so what is the exposure here? Remember, this is a smoking related ILD. So this is a smoking related ILD, and on HRCT, you find centrilobular nodules. On HRCT, you find centrilobular nodules, right? So this is what I was trying to explain in the previous slide. So centrilobular nodules, we will look at it once more. This is your centrilobular nodule. So within the nodules you have, within the lobule you have multiple nodules, right? So the presence of centrilobular nodules is seen in your respiratory bronchiolitis associated ILD. Okay. Now, what is the course of an RB-ILD? 25% have a 7-year mortality rate. So 25% of the patients have a mortality rate at the end of 7 years. But the worst prognosis amongst all of these ILDs is your idiopathic pulmonary fibrosis, where there is a 50% 5-year mortality rate. Okay. Then we will look at the next pattern, which is your systemic sclerosis and sarcoidosis associated ILDs. Okay. Systemic sclerosis. Now in systemic sclerosis, are there any exposures? Most often not. Though sometimes we do say that exposure to aromatic hydrocarbons and certain toxins can result in systemic sclerosis, but most often we do not find any exposures. Okay. So systemic sclerosis related ILD, how will it be? So this can have both an NSIP or an UIP pattern. Very, very important point. Systemic sclerosis can have both an NSIP or a UIP pattern when you do a HRCT for the systemic sclerosis related ILD. Okay. So the histopathology of your systemic sclerosis related ILD can have any of the NSIP or the UIP findings. Okay. How is the sarcoidosis related ILD going to present? It is definitely going to present with the hilar lymphadenopathy. It is going to present with a hilar lymphadenopathy. And very, very importantly, on your histopathological examination, there is going to be evidence of non-caseating granulomas. So if you are in doubt and you do not know what is the cause of ILD, before labeling them as a idiopathic pulmonary fibrosis or an ILD of unknown cause, you will have to do a lot of investigations and rule out the other known causes which can cause an ILD. So in sarcoidosis, you will find evidence of hilar lymphadenopathy, and if you do a transbronchial lung biopsy, the lung biopsy is going to show the presence of non-caseating granulomas. Very, very important. And the most important differential diagnosis for this is going to be what? What is the other condition where you get non-caseating granulomas in ILD? It is your hypersensitivity pneumonitis. Okay, fine. And what is the prognosis of the connective tissue related disorders? The connective tissue disease related ILDs usually have a 25 to 30% mortality rate at 10 years. Okay, So they have slightly better mortality rate. The reason being that they are very much responsive to your immunosuppressive medications, right? So these group of ILDs can be managed with the help of immunosuppressive medications, and that is the reason why their mortality is slightly better. Okay, so this is about the various patterns on ILD. So what all have we learned till now? We have learned about the classification of ILD, ILD of known cause, ILD of unknown cause. Then we looked at the various CT appearances and certain terminologies, and now we have looked at the different patterns, of which most importantly on CT you will have to know how to differentiate an idiopathic pulmonary fibrosis from an NSIP pattern of ILD. Clear? Fine. So let us look at how do you approach your patient with interstitial lung diseases. Alright. So first you look at the age of the patient. So when you take a history, if you feel that the patient may be a patient of ILD, what are the things that you're going to look at? So age. So when is IPF presenting? So idiopathic pulmonary fibrosis is a disease of elderly. But when you look at sarcoid or you look at connective tissue related diseases, CTD related ILDs, or you look at your lymphangioliomyomatosis, which is LAM. So this usually occurs in a younger age. Okay, so age becomes a very important factor to have a idea towards where you are going, whether what type of ILD it is. Is it going to be an IPF or is it going to be any other known cause of ILD? Then we also look at the gender predisposition. So the ILDs which are more common in females are your lymphangioliomyomatosis, which is usually characterized by cystic lesions in the lung. So it is usually characterized by cystic lesions in the lung. Or CTD associated ILDs are more common in females. Okay. The CTD related ILD which is more common in males is your RA-ILD. Okay. So always remember the CTD related ILD which is more common in males is your RA-ILD. But if you look at your systemic sclerosis or myositis related ILDs, they are all more common in females. Okay. Then we look for the duration of illness. Is this an acute onset interstitial lung disease or is it a chronic onset interstitial lung disease? So whenever we speak about ILDs, we would have been taught in our practical classes also that ILDs usually have a chronic progressive dyspnea, right? But you have to remember that there can be certain ILDs which present acutely and they have a very, very poor prognosis because the patient can deteriorate rapidly. So remember the odd features, you will remember it easier. So acute onset ILDs include your vasculitis related ILDs, your granulomatosis with polyangiitis or eosinophilic granulomatosis with polyangiitis. So GPA, EGPA can present as an acute onset interstitial lung disease. Then we have learned about acute eosinophilic pneumonia in our chapter on eosinophilic lung diseases, right? So this is your acute eosinophilic pneumonia, and another acute onset ILD which is basically a subtype of IPF, that is your acute interstitial pneumonia or your AIP. Another very important acute onset ILD is your RP-ILD, which is rapidly progressive ILD, which is seen in MDA5 associated antibody. Okay, so rapidly progressive ILD which is seen in MDA5 associated antibody antisynthetase syndrome. So what is this antisynthetase syndrome? So this is basically a subtype of myositis which can be associated with rapidly progressive ILD, right? So most of the other ILDs, your other connective tissue disorder related ILDs or even your idiopathic pulmonary fibrosis, all of them have a chronic course. Okay. So remember, whenever you take history or whenever you approach a patient of ILD, you should look at the age, you should look at the gender predisposition, you should look at the duration of illness. Then, what are the symptoms with which they can present, right? Pertaining to the lung specifically, they are going to present with dyspnea and they are going to present with dry cough. On examination, of course, you will find evidence of clubbing, you can find evidence of cyanosis in advanced diseases, and you can find evidence of your Velcro-like crepitations. Is systemic examination important? Yes. because before you diagnose a patient as idiopathic pulmonary fibrosis where there is no cause which is known, you have to rule out other conditions which can be associated with ILD. That is the reason why systemic examination becomes very, very important, especially in your connective tissue disorder related ILD or your CTD-ILD. Right? So you have to do a joint examination to see for evidence of rheumatoid arthritis. The presence of joint deformities is going to help you understand that this can be a rheumatoid arthritis. Then Raynaud's phenomenon, is it important? Yes, because this can give a clue to systemic sclerosis. Right? So this can give a clue to systemic sclerosis related ILD. Apart from that, in systemic sclerosis, what are the other things you will look for? So you will see for evidence of skin tightening, you will see for evidence of calcinosis cutis where you can have subcutaneous deposition of calcium. Then weakness, is it important? Yes, you could be dealing with a myositis related ILD. Then history of asthma, is it important? Yes, because you could be dealing with an eosinophilic granulomatosis with polyangiitis or vasculitis related ILDs. So that's why systemic examination becomes very, very important in a patient with interstitial lung disease. Then when we are looking at the history and approach to a patient with ILD, we definitely have to take a detailed history about the medications that they could have been exposed to. So the medications associated with ILD include Methotrexate, azathioprine, rituximab, anti-TNF agents, Nitrofurantoin, Amiodarone, and very, very importantly, your chemotherapeutic agent Bleomycin. Right? Then family history of ILD, is it important? Yes, because there are certain forms of ILD which can occur due to certain genetic mutations like your mucin 5p mutation or your TERT mutation. So very, very important. So this is about the various things you want to ask in history with respect to an ILD patient. Now let us look at your laboratory diagnosis. So first, in your pulmonary function testing, what type of a disease will you expect? Will you expect an obstructive lung disease or an restrictive lung disease? Yes, you will expect a restrictive pattern. So ILD is an example of a restrictive lung disease. So you will find that the total lung capacity is reduced and the FEV1 by FVC ratio will be normal, right? It will be normal or raised, and the diffusion of lung to carbon monoxide is reduced. So reduced DLCO, reduced total lung capacity, and a FEV1 by FVC normal, which is a restrictive lung disease. Then on the CT chest, what will you find? Right? So we have discussed this in the patterned approach to ILD already. So let us look at the CT findings more in detail. So the first image, which is A, can you see here that there are net-like opacities, right? We wouldn't call it opacities, but a net-like pattern, can you see like this? Right? So this is what we call as the reticular pattern. So a reticular pattern, is it part of the pleura? Yes, it is part of the pleura. It is subpleural in nature and it is involving the bases of the lung. And this kind of a reticular pattern involving the bases of the lung, subpleural in nature, is seen in which type of ILD? It is seen in your idiopathic pulmonary fibrosis. Also, can you see here these bronchiectatic shadows? Yeah. So this bronchiectatic shadows is basically your traction bronchiectasis. Okay. So this is your traction bronchiectasis. Okay. So the presence of reticular shadows involving the bases subpleural in nature with traction bronchiectasis is seen in your idiopathic pulmonary fibrosis, and this appearance is what we call as the honeycombing. Okay. Now let us look at the second CT image. You can see that the bronchovascular markings are quite thick, and do you see that this is not showing much of reticular opacities, right? Some reticulation is there, but it is not complete. Rather, it is showing this glassy appearance, right? So it is showing this kind of a glassy transparent appearance. This is what we call as the ground glass opacities. And where do you find this? You find this typically in the NSIP pattern. You see this in the NSIP pattern. Okay, fine. Now, what are we seeing here? You can see that there is some amount of organization. This is bilateral pleural effusion, and you can see that there is some amount of organization of the opacities, and this is what we call as the organizing pneumonia kind of pattern. Okay, fine. Now let us look at the image D. Can you see that there are some opacities here? These are prominent hilar lymph nodes along the peribronchovascular region. So this is your bronchovascular region. Along the peribronchovascular region, you find small nodules like this, right? So this peribronchovascular nodules is a characteristic feature of which type of ILD? So this is seen in your sarcoidosis. And the other condition, another important DD, is your lymphangitic carcinomatosis, where you have certain type of cancers which spread along the lymphatic system. Okay, so this is about the various CT findings which you can find in ILDs. Then, what is the next investigation which you can do if you are still in doubt and you want to rule out what is the cause of ILD? You can do a bronchoscopy and a bronchoalveolar lavage. So if you do a bronchoscopy and a bronchoalveolar lavage, what are you going to find? You can find eosinophils more than 25%. Then what is it? It is going to be an acute interstitial pneumonia. Similarly, if you find predominant lymphocytes, then what can it be? It can be a hypersensitivity pneumonitis, right? So bronchoscopy can help in ruling out infections, and in certain cases it can also help you to diagnose what type of ILD it can be. Then the last step would be doing a lung biopsy. Most often we can do a transbronchial lung biopsy, or you can also do a CT guided biopsy, and on histopathology you can see what pattern of ILD it can be. So can you see here, this is about the histopathological findings. Here you can see that there is a lot of fibrosis. You can find that there is a lot of fibrosis. This is your IPF pattern. Okay, and this is your NSIP pattern on histology, where you can see a lot of inflammation, and you can see that there is not much of honeycombing. Honeycombing is more common in IPF and it is less common in your NSIP pattern. Here you can see that there is a lot of inflammatory exudates which are organized well. So this is your organizing pneumonia kind of pattern. And in the last, a very characteristic feature is the presence of this non-caseating granuloma. So you have non-caseating granuloma with Langerhans giant cells and surrounding epithelioid cells, characteristic feature of sarcoidosis. Okay, so this is how various laboratory tests can be used in the diagnosis of ILDs. Okay, clear till here. Now let us look at each ILD one by one. So this is sort of a revision to what we have learned till now. So first and most importantly, we have to know how to differentiate between your idiopathic pulmonary fibrosis and your NSIP pattern. So like we have discussed before, the most common type of ILD is the idiopathic pulmonary fibrosis. It's more common in the elderly and it affects the men more than women. Okay, the NSIP pattern of ILD is associated more commonly with connective tissue disorders. So NSIP pattern of ILD is more commonly associated with connective tissue disorders, and it is seen in the younger population. Okay, how do you differentiate the HRCT findings? We have already learned. In IPF, you see the presence of subpleural reticular patterns, subpleural reticulations, honeycombing is more common in IPF, whereas GGOs are more common in NSIP. Then, in histopath, you see honeycombing in IPF, you can find cellular or fibrotic debris in NSIP pattern. So, very importantly, how is an idiopathic pulmonary fibrosis treated? It is treated using antifibrotic drugs. So, what are the antifibrotic drugs? Antifibrotic drugs which can be used, it includes Nintedanib and Pirfenidone. Okay, so Nintedanib and Pirfenidone are the antifibrotic drugs which can be used in the management of IPF. However, IPF still has a poor prognosis and it has up to a 50% mortality rate at the end of 5 years. How is the management of NSIP different from your idiopathic pulmonary fibrosis? Because most often it is associated with connective tissue disorders immunosuppressive agents are useful in the management of NSIP-ILD, and it has a good prognosis, more than 80% survival rates. Now let us look at the next group of disorders, which is your smoking-related ILDs. So if anybody asks you, can you list the smoking-related ILDs? This is what you should be saying. RB-ILD, respiratory bronchiolitis ILD, then desquamative interstitial pneumonia, DSIP, and pulmonary Langerhans cell histiocytosis. These three are the smoking-related ILDs. Okay, so exposure smoking is very, very important. On the CT chest, what are you going to find in your smoking-related ILDs? You find central and peripheral bronchial wall thickening and centrilobular nodules with ground glass opacities. So what do you mean by centrilobular nodules? The presence of nodules within these small lobules, right? So that is why we have seen the basic pattern in the CT chest. In histopath, what is the important finding that you have to remember? Accumulation of pigmented macrophages and presence of pneumocyte hyperplasia. Very, very important. Okay. So treatment is cessation of smoking. So most of the time cessation of smoking will prevent the further progression of the disease. But how much will come back to normal, it is not clear. Role of steroids and role of immunosuppressants is very controversial in your smoking related ILDs. Clear? Then the next type of ILD that we should be aware of is the cryptogenic organizing pneumonia. Okay. So how does an organizing pneumonia present? So each point here is very important. It presents in the elderlies at 50 to 60 years of age at a subacute flu-like illness with cough, dyspnea, fever and fatigue. So many a times this organizing pneumonia, though it is a pattern of ILD, initially it has an infectious trigger, and hence most of these patients will be presenting with a LRTI, lower respiratory viral or a lower respiratory bacterial infection type of picture. Okay. Sometimes it can occur in isolation underlying with a CTD, but most often the trigger is infectious in nature. Okay. So in the CT you find evidence of patchy migratory subpleural consolidations with ground glass opacities, and a very characteristic feature is that you can find that there is a rim of thickened opacities and inside there is not much of opacities, and this is what we call as the atoll sign. So this is an atoll sign, which is a characteristic feature of an organizing pneumonia kind of pattern. Okay. So many a times these pneumonias, which can be bacterial or viral in nature, can get complicated, and if they form an organizing pneumonia kind of pattern, if you see on HRCT, think of cryptogenic organizing pneumonia, and the treatment is steroids, rituximab, MMF or cyclophosphamide. All of these immunosuppressive agents have been tried in your organizing pneumonias. Then acute interstitial pneumonia is a type of IPF, but it presents acutely, very, very similar to an ARDS. Okay. On histopathological examination, you find evidence of diffuse alveolar damage. On HRCT, you find evidence of bilateral ground glassing. So very commonly, this acute interstitial pneumonias can be confused with what? It can be confused with a viral pneumonia. It is very similar to a viral pneumonia, and it presents with an ARDS type of picture. So treatment is predominantly putting the patient on ventilator, helping them to come out of this, and steroids have a controversial role in the treatment of acute interstitial pneumonia. Then the next group of disorders is your CTD-ILD. Okay. So which are the connective tissue disorders? First is your systemic sclerosis. So what are the key features that we had discussed? Systemic sclerosis ILD can be associated with either an NSIP or an IPF type of picture, and this ILD is seen in 50% of the systemic sclerosis of systemic in nature and 30% of the limited scleroderma. So please don't think that limited scleroderma does not involve the lung. Up to 30% of the cases of limited scleroderma can also have ILD. And the treatment of this is cyclophosphamide or MMF immunosuppressive agents. Then RA-ILD. RA-ILD is seen in 10% of the patients of rheumatoid arthritis, and we have learned that it is more common in males. It is more common in males. And remember, this is one connective tissue disorder which is associated with a UIP pattern. Very, very important. Most of the connective tissue disorder related interstitial lung diseases have an NSIP pattern. RA-ILD has a UIP pattern. The next connective tissue disorder, dermatomyositis, associated in 45%, right? Then we have learned about your anti-synthetase syndrome and anti-Jo1 antibodies, which is associated with rapidly progressive ILD, RPI. Pattern is NSIP pattern. Clear? So this is about the various CTD related ILD. Then granulomatous ILDs. What is the most common cause for granulomatous ILDs? It is sarcoidosis, and then we also have HSP. Okay. So with this, we've come to the end of our discussion on interstitial lung diseases. So we have looked at how to approach, what do you have to ask on the history, what do you have to look at in the HRCT, how do you differentiate IPF from NSIP, and what are the different types of ILD. Thank you.